Welcome back to the Psychiatry Boot Camp podcast. Today's topic is one that you will use in every single note that you write, literally. For this reason, you may be tempted to skip this episode. Do it all the time, you know it already. And look, most of our patients, the mental status exam is relatively straightforward. But as subspecialists, psychiatrists must be experts of our domain. We don't rely as heavily on objective lab tests, imaging, or procedures the way many other specialties do. We rely on language. And so it's vital that our language is precise. It's worth investing some time in this topic early in your training to make sure that before your mental status exam becomes second nature, you have understood all of it 100% correctly. Once you've invested the deliberate time to make sure that you've filed away all of the information accurately, you can more easily justify being a little bit less critical of your own thought process. The other thing is, the mental status exam is a very medical, legal, and objective portion of our note. And from encounter to encounter, you or the next doctor can look at a past mental status exam to give some idea of what the patient was actually like in the room, which is vital for assessment and treatment planning and knowing how the patient has progressed over the course of sometimes years. And I hate to hold this over your head, but not enough to prevent me from doing it. If you're ever on stand, whether it's for an involuntary commitment hearing or some sort of litigation related to your medical practice, you are going to be asked about and held responsible for the content of your mental status exam. I don't think I need to overstate this. You're going to want to make sure that your language is correct and that you're documenting what you think you are documenting. For example, mixing things up like tangentiality and flight of ideas, or hallucinations and illusions, or a constricted affect from a blunted affect could lead to some difficulty defending your mental status exam. There are several portions of this episode that change the way I think about certain foundational concepts, perhaps pressured speech being the most profound, so look forward to that. The mental status exam isn't something where a whole lot of ongoing research is being done. It's more of a convention handed down over generations, and it's understood differently across various psychiatric orientations, locations of training. And this means there's really no real authority on the mental status exam. So I've decided to bring on the editor-in-chief of the World Journal of Psychiatry, just to err on the safe side. Welcome to Dr. Rajesh Tampi, and Dr. Tampi, I'll ask you to introduce yourself to our audience.
Thank you, Mark, for having me in this program. My name is Raj Tampi, and I'm the chair of psychiatry at Creighton University School of Medicine in Omaha, Nebraska. I'm also the past president of the American Association for Geriatric Psychiatry.
Okay, so first things first, why are mental status exams so important?
So as you know, Mark, we do not have any tools like lab tools or other things to diagnose psychiatric illnesses per se. And all tools that we have available, including neuroimaging studies, only are suggestive of certain things, but they cannot definitely prove. So the mental status examination becomes our tool to assess how the patient is doing and come up with a diagnosis based upon how the patient is presenting in addition to the history. So mental status examination is front and center to our diagnosis and then deciding upon a treatment plan for our patients.
Gotcha. So in my training so far across different health systems, different levels of care, different attendings, I've been very surprised how much variance there is within the mental status examination, especially considering how fundamental it is. Most of the time, they're formatted by category. Sometimes I see it in paragraph form. I've also noticed that the content of the mental status exam itself can change. So, for example, sometimes things like psychomotor activity and attitude are pulled out into their own category. Sometimes they're folded into one category. So, from your gestalt,
Right.
why do you think there is such significant variance? Do you have any thoughts on like the most appropriate way to structure and document the material?
Correct. So, European School of Psychiatry is very different from American School of Psychiatry. So I was trained in the European school. I went to training in England. That is a very formalized way of assessing mental status examination. So majority of the people who are trained there will tell you there is one particular way of doing it. Now, is that the only way? I don't think so, but it's an organized way. It's like learning how to cook. I mean, if you do, whether you should put salt first or, it depends upon how you do it. But I do it in a particular way, which is most narrative, because we don't have specific diagnostic tools. So I cannot show an EKG and say that this is what a patient with schizophrenia looks like, versus this is how a bipolar patient looks like. So my history and mental status examination should prove that to the person who's reading that. It's not to prove to myself, but it's to prove to anybody else. So for example, if after my call, you're coming in, I have assessed the patient, You should be able to just look at the mental status examination and look at nothing else and say, oh, Raj is talking about a patient who appears to have bipolar disorder. So for me, that drop down boxes does not work. I always do a narrative because narrative has much more depth and breadth in terms of explaining what my patient really looks like.
You feel like you're able to be more precise when you take a narrative
Very
approach.
Yeah. You should be able to see, it should be like you're blindfolded and you just read the mental status examination. You should be able to tell whether, it's a man or a woman, what their race is, how they look, how they're interacting with you, or at that particular moment of time, what their affect and mood is, what their speech is like, what their thought process is like, what the thought content is like. Are they having any perceptual abnormalities? Are they having any suicidal or homicidal thoughts? And how is their cognition? Are they cognitively intact versus cognitively impaired? And if impaired, how much so? And do they have good insight and judgment?
Thank you for laying that out for us. And so we'll go in detail into each category and some of the different descriptors that you might use. One thing I'll ask you just before we dive into that, is there anything that you sometimes see in mental status exams that you recommend for sure we don't include?
I think that sometimes again, it is not that often now because everybody uses a drop bad money. When you used to use narrative, people would use negative terms to describe patient, which might be problematic medical legally nowadays. And it might also, if somebody else reads it, it might show that you are not a thoughtful person to be doing that. So just don't use adjectives for the patient, just use clinical descriptors,
Gotcha. This is not the place to editorialize.
Yeah.
Or introduce
Absolutely.
bias.
Because it's a medical legal document. Every document in my term, and I say this to trainees, is a discoverable document. And you have to write it exactly as you see it in a systematic way so that when somebody reads it, they know exactly what you have said. And if you're not done it, you can say, I did not do this. For example, we don't check cognition repeatedly every item with a patient. But when the patient is presenting a coherent history, it has come to the appointment on time, is knowledgeable about the social events, we say that the patient's cognition appears intact. And I say it exactly that.
Perfect. So let's go ahead and dive into some of these categories that you just mentioned. Let's start with appearance. What kind of things are we looking for with appearance? What do they tell us? What are you going to include in this portion of your exam?
In my exam, so I include, man or woman, how they appear, both in terms of hygiene, dressing. Are there any abnormal movements that you're seeing, right off the bat? Person is very fidgety. The clothes they're wearing, are they neat? Are they dirty? Then I also sort of talk about how they relate to the environment they are and particularly with you. Some people may be very comfortable sitting in the chair, but maybe very hostile towards you. So I do that because then the person who's reading that mental status examination would be able to say that, oh, they're comfortable with being in a psychiatrist's office, but did not particularly like the psychiatrist or had something that was going on. So it gives you a cue about what their thought process is like.
What about including things like grooming and clothing? What does that tell us about our patient?
It tells us if the patient has been able to take care of themselves, because many patients with mental illness, especially the people with chronic SPMI, serious and persistent mental illness, don't take care of themselves. So it gives you a little bit of cue into the patient's cognitive process and abilities to take care of themselves.
And to your point, Dr. Tampi, about being narrative and not simply doing a drop-down menu that has 3 choices, in appearance, this is where you might include things that would not be on that drop-down menu, like evidence of self-harm if they have that, if they appear cachectic, what their posture is, that's not going to be present in a drop-down menu. And for some patients, it might not be relevant, but for others, it's absolutely vital. It gives you really important clinical information.
And the problem with these drop-down menus is that I cannot even tell if you're talking about a man or a woman and if they're Caucasian or, African-American or Hispanic or Asian Indian. I can't tell, so I'm like, yes, you can look up the name and all of those kind of things. But you know what? If you're in a busy doctor, you're looking, it should tell you everything. It's like an EKG. It tells you whether you have a heart block or not.
And while we don't editorialize mental status exams, I will editorialize just briefly here when including things like race and ethnicity in the mental status exam. Let's not just assume, we have these drop-down menus. And so it can be tempting to just, okay, I think this is roughly correct. Again, this is a legal document. So if you're going to include something like that, make sure you're asking the patient, how do you identify? What is your cultural background? You really need to be correct in your mental
Right.
status exam. So just kind of a word of caution there.
Absolutely. And that is why if you've not done it, don't write it. And you know what? If you're going to write about those things, you should ask. And that should be asked right up front in your history taking. Remember, you're breaking the ice and getting to know the patient. You ask, how do you identify yourself?
Okay, moving into the next category, this is behavior. So what types of things are you including in your behavior portion of the exam?
Behavior, as I pointed out earlier, you include how the person reacts to the environment, how the patient reacts to you, and any other situation that they're coming in. You also talk about whether they appear restless or calm. You also talk about any abnormal kind of things that they're doing, like tapping their feet, humming the tune, fidgeting and those kind of things. So those are the things that I actually include in the activity portion.
Do you file attitude under behavior or do you save that for somewhere else?
You know, Attitude, I don't use that. That's not a clinical term. Uh, I say relationship to the exam.
And that could be like cooperative, hostile,
Yes.
evasive, apathetic, things like
Yeah,
that.
exactly. Exactly.
And then you're also including psychomotor activity here.
Correct. Correct.
Okay.
Because it tells you about the mental state of the patient. If the patient is calm, sitting through the appointment, although, all of us get anxious going to doctors. As I do. I mean, even it's a regular routine work. Think about coming to a psychiatrist. If patient is calm, you're like, okay, maybe they're well adjusted. Either they've seen a psychiatrist before or they have thought about this, whatever it is. You just describe it as this. If the patient is very calm, but saying all these delusional things, then you would wonder why. What has happened? Has this person talked about it, or is the patient holding something back from you, or are you not getting the full picture of what's really happening, or is this patient medicated? These are all
Right.
thoughts that go into your head.
Okay, so that kind of describes the patient's behavior. Moving into speech, what do we want to know about the patient's speech?
So in my mental status examination, put any gross abnormalities of speech, just by hearing them. If you're, hearing stuttering, if the patient is speaking in volume, low volume, normal volume, high volume. If the patient has a rapidity in the way the patient is speaking, very fast or in a normal tone of voice. Any lack of inflections, monotonous speech, usually seen in Parkinson's disease, hypophonic speech seen in Parkinson's disease. So both the quality and the quantity of speech. The quality, you would include the inflections in the speech. You would talk about the rate of speech, and you would talk about any other abnormalities like stuttering and those kind of things.
In terms of the rate of speech, could you walk through the difference between talking fast and pressured speech?
Yes. So a pressure of speech is a function of the pressure of thought. So, in rapid speech, the patient usually appears anxious and they're talking really fast, but it is the same idea which is linked together. Whereas in pressured speech, patients will have multiple different ideas. So if you look at a manic patient, they go ideas. So it's a flight of ideas in terms of speech. It's the thought process that defines it.
They have so many thoughts that they just simply can't talk fast enough to get them all out.
Correct. And sometimes you may not be able to link them together. So the difference between those is the anxious person has a fast speech, whereas a patient who is manic clearly has a pressured speech.
That is very helpful for me because one way that I learned that is pressured speech is speech that you cannot interrupt. And I always thought that doesn't really exist as a clinical entity, but that's not really what you're saying. What you're saying is you're using the speech to kind of assess the thought process, which we'll get to.
Yeah.
And that's what the pressured speech is it's speech that is the result of a thought process that is so fast that they can't get the words out.
Right. And there are so many thoughts. In an anxious person, it is this linear thought. Their anxiety is driving the thought, oh my God, I did something wrong. They're not saying I did something wrong. I am great. I am Jesus. I could fly. Manic patient may have all of these things. So it's like a water flowing very fast versus water flowing not only fast, but the amount of water is higher. So it's almost going to burst the pipe.
Perfect analogy. The other thing I want to zone in on in speech, because it can be a helpful clinical tool, is latency. What is speech latency and what does that tell us diagnostically?
Very good. So remember, again, speech is a product of your thought process. So in patients with schizophrenia, sometimes they may have thought blocking, which is the final stage of the latency of speech. People just can't get the thought out. Whereas the classic latency, where there is a delayed speech, can come with neuromotor functioning abnormalities like neurodegenerative disorders, or it can come from people who are profoundly depressed. So you have to correlate the history and the presentation and how that is happening. So a person who has masked facial features now starting to have cognitive issues and having speech latency, probably Parkinson's disease. If the person has no other abnormalities with all the neurovegetative symptoms with the latency of speech, that is probably depression.
Perfect. So our listeners will see how this is a medical legal document, and really when they're documenting the mental status exam, they are building a case for their diagnosis, their formulation, their assessment and plan. And so you want to make sure you're being correct with your terms, because as the reader is reading your mental status exam, they should get an idea of sort of where you're going with your assessment.
Also, like another important point, if there are discrepancies, so if they don't all add up, that is perfectly fine too. So it tells you that there are other things going on which are not obvious. If a person with profound depression has speech latency and has masked facial features, this may be a person with the development of a neurodegenerative disorder that nobody else has diagnosed. It has happened in my case where I first saw the patient and I'm like, why is this person being admitted to my unit with Parkinson's disease? They're like, no, she's being admitted for psychotic depression. I'm like, this is not psychotic depression. This is a person with Parkinson's disease. And we called the neurologist, and the neurologist agreed. We gave the person help, the Cinnamon, and the patient was better in 3 days. And I discharged her without any antidepressant. So again, if there are discrepancies, as a clinician, it is your responsibility to call it out.
Calling balls and strikes in the mental status exam. So if it doesn't all point in the same direction, that's okay. If you're not comfortable living in the gray, you might reconsider your field, because there's a lot of difficult decisions that we have to make in psychiatry.
Correct. And sometimes our first initial thought may not be the right one. That's why you have colleagues. You talk to people about this. This is science here. We are using art form in organizing these things to develop a scientific document to make a scientific diagnosis. We all make mistakes and we all get caught up in how the patient is presenting. So whenever you reflect upon these cases, you should also ask about, what was it about the patient that made you make a wrong judgment? Was the patient, had you so focused on how they spoke that you completely missed what was going on beneath? I had a patient that I interviewed with the residents of Cleveland Clinic. For 30 minutes of the interview, the patient held the full conversation without giving out any symptoms. But when we came to talking about stressors, she started talking about the neighbors plotting against her and everybody. And this person was so delusional that they held it together. But when you started diving deeper into that, that's when it came out. So sometimes a quick assessment gives us the wrong picture. So that's always, ambiguity is not a bad thing in psychiatry, because it tells us we're all human and the patient is human.
In the case of the mental status exam, what would you say to somebody who's not sure what word to write, for example, for speech? How do they handle that? If even I can't make up my mind about what the clinical entity is.
Describe what you saw.
Okay, moving into mood and affect. How do you describe to learners what mood is?
Yes, mood is the inner feelings of the patient, which is described to you by the patient and which you think is going on. Whereas the affect is what you see in front of you. And I only describe one thing. I only describe the range of affect and whether it is congruent with what you're seeing or how the patient is presented. So for me, the range of affect is either flat, which is completely like in a patient with Parkinson's disease, nothing. Classic flat affect is Arnold Schwarzenegger when he just said, there's nothing there. It's classic flat. And then it is a restricted range or a full range of affect. And if it's a full range, you may go into when the patient has an expansive affect, somebody who's very happy. You can clearly tell it in a manic patient. That's all I describe it. I don't use blunting because I was taught that blunting is not a range. It is a quality of the act. And blunting, I have never really seen. Blunting is when the patient describes something that is not congruent with what the patient is saying. So I never use the word blunting at all. People use blunting as if they say a sharp tool and a blunted tool. That's not what it is in psychiatry. If you actually read any of the psychopathology textbooks, they will tell you that blunting is a quality of the affect, not a range of the affect. But American psychiatry, I think people just use it as a lay term. I don't. I only describe it as flat, restricted, full, expansive.
Are you including anywhere in your mental status exam anything about the quality of the affect? I guess not then. You're just
Yeah,
including that.
it is incongruent or congruent. So if the patient has lost all her family and she has a bright affect, that is an incongruence there. So I would say the affect is incongruent to the current situation.
Likewise, if I have a suicidal patient in the ED and they're telling me, I'm fine, I'm really great, life is great, I'm doing well, and the look on their face just says, my life is falling apart. That would be an incongruent affect.
Correct. So an incongruent affect is like terrible things going on and you're like smiling brightly. And the affect is not congruent with the situation or the mood that you are describing. You're describing all the neurovegetative symptoms, but you're smiling brightly. Well, it could be malingering for you. So again, see, the incongruence is what makes you think, what is exactly happening? Is this real or is this made up?
And so then in the mood category, you're putting certainly what the patient actually says in their own words, in quotes, but then are you also including there things like euthymic, dysphoric, euphoric, anxious, irritable?
Well, those you can describe it both in part of affect because you're seeing irritability, right? The patient is flushed in the face. So when those kind of situations happen, I describe it for the person. The patient appeared angry because flush face, the pupils were dilated, the patient was leaning forward. All those describe the situation that the patient is in. So just describe those situations. By just describing, okay, the patient had irritable affect. What does that mean? I don't know. It could be many different things. So I would just describe those situations because, in terms of irritability, it can be both as an affect, which you're seeing, and it can also be the mood that the patient is describing. So when I'm in a situation where I'm not exactly sure how to state with one word, I describe it because then the reader knows exactly what is going on. And you can also put subjective and objective presentation. In the affect is, of course, it's an objective assessment of what is going on. In mood, you can say objectively, the patient is reporting all depressive symptoms, but subjectively, she's saying she's not depressed. You could describe that too. So you could add that as a qualifier. Again, telling you that there is a discord between what is being described and what's being seen.
And again, as the expert, feeling free to overrule those electronic health record dropdowns.
Correct.
Okay, moving into perception. How do you describe perception?
Yes, perception is what the sensory modalities feel, the 5 sensory modalities feel, and any abnormalities in those sensory modalities like vision, hearing, taste, touch, all of those abnormalities you can describe. Then you have to describe there between illusions and hallucinations. Illusions are false perceptions in the presence of a stimuli. So you misinterpret. So you see your cord lying on the floor, you think it's a snake because it's dim. You see the curtains moving and you think that is somebody there. So it can happen in any way. When your sheets are light and they're touching your skin and you think, oh my God, somebody just touched you. Those are illusions. Whereas hallucinations are false perceptions in any sensory modality in an external space. So I always ask people when they say they hear voices, I say, are they inside your head or are they outside like you and I are talking to me? Because if those are inside, then you want to know whether they are ruminations, which are the patient's own thought processes that are just saying, oh, you're a bad person. Whereas it's different when it's in the external space, you're hearing it like another person's voice or another noise.
So good example of the difference between illusion versus hallucination would be like my phone is in my pocket right now and I move and I think that it vibrates. That is an illusion. I'm misperceiving what is a real stimulus.
Right.
However, if my phone is not in my pocket and I
Yeah.
think I feel something vibrating in my pocket, that would be a tactile hallucination.
Right. And
Okay.
not all hallucinations are pathological. So hypnagogic and hypnopompic hallucinations, they're abnormal, but they're not pathological. In a state where extremely tired. And I remember when I was an intern, I was in colon neurology. I really thought that I heard my pager go off. And I jumped up and I picked up the phone and I said, let me just check my pager. it had not gone off. But because it was early in the morning and it was a very long call, I was exhausted. So I thought it was a real noise, but it was not. So not all hallucinations are pathological. They are abnormal. But the clear hallucination, like somebody talking to you and telling you bad things, asking you to do stuff, a command hallucination, somebody talking to the others, third person hallucination, referring to you as, oh, that person is bad, this person is, not good. Those are clearly, those are pathological.
Right. So 15, to your point, 15 to 20% of people will hear voices at some point in their lifetime, but far, far fewer than that have a diagnosable psychiatric illness or a primary psychotic disorder.
And if you look at the epidemiological catchment survey, 16 to 23% of older adults, because I'm a geriatric psychiatrist, have psychotic symptoms, but you don't treat all of them. I mean, so you only treat symptoms that start to impair the functioning of the individual.
So when a patient does endorse auditory hallucinations, what other questions are you asking about those hallucinations?
Right. So you need to get more details. What kind of auditory hallucination is it? Is it a man, a woman, one person, multiple people? Are they talking to you? So this is a command auditory hallucination, which is more severe psychopathology. Are you hearing it in a third person hallucination, where people are talking among each other about you? These are all details that you want to get. More complex hallucinations or more thematic hallucinations with details is that the person is more ill. That's basically it.
Gotcha. And the most common type of auditory hallucination for our listeners is derogatory auditory hallucinations. So this is somewhat culturally informed. So in the US, in males, it's most commonly homosexual slurs, and in females, slurs for promiscuity.
Correct. Because, remember, these hallucinations are ego-dystonic. They actually make you feel bad. If it's hallucination saying that you have all the powers in the world and you're the best at whatever what you do, patients will be happy. I can count on one hand how many times I've had patients say, oh, I hear that I'm fabulous. Also, these sort of hallucinations change with culture. Religious hallucinations, where God talking to you, devil talking to you, all were much more common. But as society evolves, the hallucinations also evolve.
Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word boot camp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, bootcamp. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Okay, moving into visual hallucinations. What do we need to know about visual hallucinations?
Remember, visual hallucinations are much more complex phenomenon to occur. So it needs a lot more brain area for the visual hallucinations to occur. So when you have visual hallucinations, you're just basically asking them what exactly is seeing. And all visual hallucinations are, again, not pathological. Charles Bonnet syndrome, something which is seen in older adults. These are the individuals who present with just visual hallucinations without any other psychopathology. The majority of them are going to develop Alzheimer's disease and other neurodegenerative disorders later on. But at that time, they have vivid visual hallucinations, but no auditory hallucinations. and they just see these things because many of them also have degeneration of the retina. So, macular degeneration. So they see visual hallucination. So not all visual hallucinations are pathological. They just say that multiple brain areas are involved. So I ask them about details of what you're seeing. And I always ask patients whether they are hearing auditory or visual hallucinations. What do they do for you? Do they make you happy? There are people who have auditory hallucinations of their loved ones or visual hallucinations of their loved one when they have lost, especially young mothers who have lost kids. It's soothing for them. So not all hallucinations, like you said before, are pathological. They're abnormal.
Most common visual hallucinations are humanoid, could be shadows, could be figures. And anytime you hear of especially an isolated visual hallucination, it should definitely prompt you to think more medically, more neurologically. Have they had recent headaches? Have they had new onset seizures? Things like that.
Correct. So remember, like I said, they're not always pathological, but they're abnormal. So you need to know why they're happening.
Okay. Also want to touch on in perception, derealization, depersonalization. How would you define these categories?
So, Mark, that is the difference. So in Europe, we would not use them as perceptual abnormalities. These are anxiety symptoms. So derealization and depersonalization are not seen as pathological. They're seen as abnormal, as anxiety symptoms. So I never put them in perceptual abnormalities because remember, these are sensations, but whereas these are, in the way I was taught, they are thought abnormalities. So I put them in there.
So you say, back to my initial point, it's not one of the five senses.
No, exactly.
Gotcha. Perfect. That's going to change the way that I practice. Okay. Moving into thought content.
Yes.
What do we want to know about the patient's thought content to document?
Yes. So first and foremost, you need to know whether the thought content is known and the thought content is abnormal. Then you want to know abnormalities of thought process and then of what else the content has. So we need to talk about the thought process first. Remember how the thought is being laid out. Most people have linear thought process. So they go from point A to point B. Sometimes people may take a little time to come to point from A to point B. So you need to know about how linear it is. If there is no linearity, how severe the abnormality is. Now, this patient is circumstantial. That means they're all around the place, but they will come to a point later on. If they are over-inclusive, they add too many details, ultimately they will come to the point. Or the patient has significant tangentiality. That means, it skips, it goes everywhere. It may come to a point, but it may not. In schizophrenic patients, there is one, what we used to be taught in England is called Knight's derailment, when the thought process is completely derailed, that you never get to the point at any time. So it talks about the pathology of the individual. Again, when you see abnormalities of thought process, they show abnormality, not always psychopathology. So, anxious people may actually have circumstantial thought process. People who are from different cultures may be over-inclusive in their thought process. That, you're like, I always joke and say Indians sometimes are over-inclusive. I don't need to know all the details about that, but just give me the point. And it's culture. So it's not always a normal. But of course, then the tangentiality and, the Knight's derailment, those are all severe forms of thought process. Thought content. Thought content has obsessions, it has ruminations, and it has delusions. And of course, we talked about, if you remember in the last talk, over-inclusive ideas. The difference between obsessions are that obsessions are your own thought processes that go over and over again. Overvalued ideas, they are a normal idea that is held with a fixity which you cannot change. Like, remember the example I gave of a security guard who was assaulted severely in the prison. So she thought that she was being followed all the time. She was. Initially she was, but then 5 years later, nobody's following her, but she still believes that is happening. In a delusion, the content of thought is clearly abnormal. It is not keeping with your cultural, social, educational, religious backgrounds. And it is held with a fixity that you cannot change. For example, you have patients coming and telling them the FBI put a chip in their ear and now they believe that they can hear everything and they can see everything. And I'm like, how is it possible? Well, they give you a big story about how that is possible. So those are the things that are clearly delusional. Religious delusions used to be much more common, but they're becoming less common as the societies evolve.
In our thought process category, I want to touch on some words that I think our learners are probably hearing in medical school and get your thoughts on them. How does loose associations compare to that Knight's derailment that you talked about?
So Knight's derailment and loose associations are very similar, where loosening of association, remember, it is the worst form of Knight derailment, if you can call it, that there are no linkages with any thoughts. And I have, in my practice in 20 years, I have never seen one. I've never seen a true loosening of association. We don't see them anymore because before the patient reaches that level, they're usually treated because that's a very severe psychopathology. And usually it's very destructive and somebody has seen them and treated them with something.
Okay. And what about flight of ideas? How does that contrast with tangentiality?
Yes. So flight of ideas, it's like, think about a plane taking off, running on a runway, right? So the flight of ideas, there's a fast process, but eventually it may get to the destination. So that is how I see it. And flight of ideas are commonly seen in patients who are manic. That is different from loosening of association, which there is no connection between the thoughts. It's all over the place. And I have never seen one truly as of this time.
Another couple of fun things that I just want to make sure we mention in thought process, things like neologisms, where patients are coming up with their own new words that have a meaning to them, but not to others. And on that same token, clang associations, where patients are associating one word with another word, not because they make sense contextually, but because phonetically they sound similarly. And I've been shocked actually by how often you see that when you're dealing with a patient who has a somewhat psychotic thought process.
Right. But you can also see that in patients with intellectual disability. So again, it is abnormal, but not clearly pathological. So that's why I tell everybody, nothing is absolute. So don't take one piece and run with it. It's like a jigsaw puzzle. You put the information together and see what pattern develops. Because when clinicians are, not yet seasoned, I saw this. Oh, that might be why this is. No. I'm like, there's more to the story than what's going on. Look at the information. If all the symptoms fit, if the information does not fit, why is it not fitting? And have a differential diagnosis. That's why we have a working diagnosis when we see a patient, and we have a final diagnosis or diagnoses once we get to know the patient better.
Right. Because if you're manipulating the clinical information to meet your view of the situation, you're going to end up admitting a patient with new onset Parkinson's disease to the psychiatric hospital. And you can do real harm when you do that.
And it really happened. It really happened at Yale Neural Hospital. I was like, why is this patient here? And it even happens to seasonal clinicians. So I always say, if in doubt, what I say is stop the press. Let's review everything. And let's talk to somebody who knows more about it. And I have found that to be the best tool to date to help serve the patient. Remember, it's not about jumping and developing a treatment plan. It is developing the appropriate treatment plan for the patient at that time.
I want to dive into a couple of other terms that we're going to see in our thought content portion of the exam. One of them is ideas of reference. Could you explain that to us?
Ideas of reference in my training is they're abnormal, but not pathological. Ideas of reference is when patient says that something is related to what is happening. And I usually equate it to a paranoid thought. So remember, paranoid thoughts are self-referential, but not pathological. People can be paranoid because of, how they were brought up. It doesn't necessarily say the patient has schizophrenia or other psychotic illnesses. So the idea of reference to me is part of the paranoia. So it's like, it's like mirror images of those. So I never use that word idea of reference. I always use whether the patient has a paranoid thought or not.
Would you put paranoia in thought content?
You certainly can. If you feel that it is important to describe that, you can say the patient describes paranoid thoughts. But I might also, in my summary, I would say that although the patient describes paranoid thought, it could be better explained by the patient's history of trauma and the upbringing, in a rough neighborhood. So again, it is what you describe. The idea of reference is not necessarily pathological. It's abnormal, but it's not pathological.
I hope our listeners are hearing Dr. Tampi sort of redirect me away from thinking so narrowly about what can go in each area. We are calling balls and strikes. We're thinking broadly. We're not limiting ourselves and our possibilities of what we can document just because of convention. We call it like we see it. We put down the objective information and then we put it all together in our formulation. Other things in thought content, what would we want to say here about suicidal thoughts?
Yes. So, I put that as a separate category. I don't just put it in the thought content. I put it as a separate category because it's a part of risk assessment also. So I put both suicidal and homicidal thoughts because, a lot of patients who have suicidal thoughts can also commit homicide. So you need to assess both of them. So I ask in detail about whether the patient has a suicide. It's a thought, whether they have planned it, what extent it is, whether they have done any concealment, whether, any of those. And as much details as you can, because if the patient has premeditated, has made sure that nobody's there to help them out, if the patient has written suicide notes, if the patient has tried to do this before, the risk of completed suicide is much higher. So I actually put a full narrative there.
Right. And certainly with suicidal thoughts, is it active? Is it passive? Is there intent? Is there a plan? That's the absolute bare minimum. And what you're saying is, again, go beyond that. Be narrative about it. Talk about what the patient actually said and what they're feeling.
Exactly. And, don't just say patient has active suicidal thoughts. Okay, then what is the question? What did they say? Active suicidal thoughts of killing themselves 5 years down the line. That's not passive because they're telling you. So what exactly it is, because that's also a risk assessment because remember, it's a medical legal document.
It reminds me of a patient that I have who tells me, yes, at some point I'm going to end my own life. There's nothing anybody can do about it. He has a very independent streak in him and he is getting older. And he says, at some point I'm going to end my life.
Right. So, a good example, Mark, is if a patient says, you know what, I have a family history of Parkinson's disease. If I get Parkinson's disease, I'm going to kill myself. Well, it's in so many ifs, right? So when patients say that risk is lower, so it tells you right away, and it's your duty to get more information about what exactly was being said.
And we don't need to oversimplify it or wedge it into a bucket of active or passive suicidal ideation. We can just say what is actually happening to the patient.
Correct. And that is much more helpful to the person who's reading the note and making an assessment rather than saying active or passive suicidal.
The only other point on homicidal thoughts, one thing you need to make sure you ask if they're having any sort of homicidal thoughts is there a specific target in mind? Because that will really inform your management.
Correct. And then if in doubt, remember, you always have your risk manager on call. Tell your attending right away, talk to the attending, and you should talk to the risk manager and decide the next steps, because sometimes it can be very blurred. They say, oh, I'm going to kill somebody here, but I'm not sure. Well, don't just keep it by yourself. You want to make sure that you're doing everything, because wherever you are, I think majority of the states have South ruling where you have the duty not only to inform, you have a duty to protect the individual. So, make sure you talk to the legal because they are aware, they can keep a note of this. So if anything happens, you're backed up by your team.
Okay, moving forward, cognition. What are we going to put in cognition for our mental status exam?
So cognition is a elaborate process. So people mistake between mini mental state examinations, a state exam versus cognition. So if you are going to do a formal cognitive assessment, you should do that. So you can do mini mental state examination. Unfortunately, it is copyrighted. MOCA now, Dr. Nazaruddin has it. You have to go on the website. You have to sign up to do that. Slums is not yet copyrighted. I'm sure that in a few years that will also be copyrighted. So if you go to formal testing, you can use that to do it. The difference between mini mental state examination and MOCA and slums is that you have the MOCA and slums check more of your executive functioning. And so they will be able to tell you about mild neurocognitive disorders or mild cognitive impairment. But if you don't have access to anything, you want to do a cognitive testing without standardization, then there are certain things that you want to ask. You want to ask orientation in all the spheres, time, place, and person. You want to look at attention. You want to look at concentration. The difference between attention and concentration is attention is the ability to focus. Concentration is the ability to maintain the focus. So asking for the 5 words forwards and then asking them to remember them later on after 2 or 3 minutes is attention followed by concentration, or asking them to spell, world or chair or whatever forwards and then backwards. So attention is ability to focus. Concentration is ability to retain the focus. Then you want to ask about language. Then you want to ask about executive function. Then you want to ask about memory. And then you want to ask about insight, which is the ability of a person to use information, awareness of the information and what their problem is. And judgment is ability to use that information to make a plan or what they're going to do about it. So it is orientation, attention, concentration, language. You can check praxis. I usually don't check praxis formally because I can see people doing their things, moving their hands, adjusting the ties, because praxis is the ability to learn motor movements. Then I do the executive functioning. Executive functioning, you can ask them to do some calculations, some word fluency, some word category testing, some math problems, simple ones, and then insight and judgment. That's what I do.
So moving into our insight category then, if we're doing this in the American way with the different categories, what type of words are you using to describe the patient's insight? And when you say you're asking about insight, how are you querying them?
Very good. So I asked about 3 or 4 things, because remember, you're asking about insight for the patient about their particular illness or presentation. You're not asking about insight or judgment, whether they can get married or whether they can do their bank account. That's not what this is all about. So I never say the patient's insight is good. I describe it. So I ask questions. Okay, what is going on now? Doc, I'm ill. I think I'm depressed. I have a lot of stressors. I think I need help. So in the understanding about the illness, then I ask about what do you think should be done? Doc, I think I need to be on medication. I think I need to get admitted. So what do you do? Then I ask about what if you don't follow those things? Hey, if I don't take medications, I'll get more depressed. I might become suicidal. My family life will go. And then I also ask, what will you do if in an emergency situation, if your illness gets worse? So you know what? I'll pick up the phone, call my doctor, make sure I come to the emergency room. So I ask those questions. I don't ask questions like, what if you find a letter on the road? I mean, schizophrenic patients I'll just mail it. And then of course they're not taking the medication, So I always ask about their situation. So contextualize it in what their situation is and use that to understand insight. And remember, I always ask insight and judgment are similar, not the same. People can have good insight, but terrible judgment. An alcoholic knows drinking alcohol is bad, but he still continues to drink. And that is why I asked about, hey, what happens if there is an emergency situation? So I asked both of those.
I will admit that I think this was initially taught to me with you find a stamped addressed letter on the road, what would you do with it? So I will delete that.
People ask us, I asked about what will you do if there is a fire in a theater? Well, who goes to theater now, because of the pandemic? Second thing is schizophrenic patients will run out. Well, they have good insight and judgment about what will happen in the theater, but they know nothing about their own illness and taking medications. So I ask everything in context of what is happening, because our assessments are time limited and situation specific. It is only good for this. It's not good for tomorrow. It's not good for what happened in the past. So everything is contextualized to that. So wherever there's a word that I don't know, I just describe it.
So we're not getting at the patient's insight into the nature of the universe. And we're not if we were to broaden this more, what we're really doing is introducing an opportunity for us to pollute the information with our own biases.
Correct.
And we want to be as objective as possible. So we're asking them a question about their insight of their illness as it stands right now. And that's going to help us to be a lot more objective and a lot less biased with this information. And likewise with judgment, I think this is often a Gestalt thing. What do I think the patient's insight and judgment is? And it doesn't need to be. And what you're saying is it shouldn't be, because it really should be a more objective in the moment assessment of what the patient is saying.
And I always say that because everybody comes from a different background. Everybody comes from different cultures. So when a person who is reading a narrative can understand how abnormal this is, irrespective of all your differences. So it should be as descriptive as possible. In your summary, when you do your summary, you actually can capture what you think. That's where you say, this is where I think it is. So that's where a person can, okay, I saw this, but this is what I think is going on. Perfectly fine as a doctor to be able to judge it. But the history and the mental status examination should be as descriptive as possible. I see people writing adjectives on all kinds of stuff. It's unhelpful because that's your thought. It is not what really happened on that day or that minute. So describe it as much as possible. And I always say, you're dealing with a human being. You have a fiduciary relationship to the patient. You have to represent them exactly as it is, and then make the decision that is in their best interest. So how can you do that when your own limitations are clouding everything you're doing?
I have to admit, Dr. Tampi, I have learned more than I thought I would from this conversation. And I kind of regret bringing you on because as my clinic supervisor, you get to read all of my mental status exams. So I hope you'll continue to be kind with me as I work on implementing these changes to my exam.
And again, remember, it's the human interaction as your supervisor. My goal is not to critique you. My goal is to make you get better at what you do, which is taking care of people. And, this is a human interaction every day. That's why psychiatry will exist no matter how much technology takes over, but because no machine will be able to tell how another person is feeling. Only a human being can do. So keep this simple, keep this descriptive, keep it here and now with what you're seeing. And when you're doing a mental status examination, try to think not in drop-down menus, try to think about more descriptors because it'll be easy for the person to understand. And then if there are any disagreements or discords, that's where your summary comes in. That's where you tell the person, hey, I saw this, but I'm not sure how to put it. And then you should use your differential diagnosis. Don't have one diagnosis. Have differential diagnoses that you develop because, mental illnesses are not simple.
Dr. Tampi, any final thoughts for our listeners?
The only one final thought is enjoy the learning and enjoy making mistakes because that's where you will learn.
And you'll get to hear Dr. Tampi again on our capacity assessment episode. So look forward to that. Thank you for your time, Dr. Tampi, and I will see you soon.
Thank you very much.
Bye. Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.